related factors.
Sharon?
Hi everyone, I'm Sharon and I'm a postdoctor.
Okay, so we're a tiny bit ahead of schedule. We'll wait about 2 more minutes, and then.
Can you hear me now, by the way?
Yes, Ron, we have minutes for you to speak. You have introduce yourself, Ron, please.
Oh, Ron Lee, Demography and Economics, and glad to be here.
Hi everyone, I'm Maddie. I'm a postdoctor.
Okay, and with that, let's turn it over to Ray, who's going to introduce our speaker today.
So Martin Eiermann is a postdoctoral fellow in the sociology department at Duke University. He holds a PhD in sociology from UC Berkeley and a BA in history from Harvard University. His current research examines how social histories and patterns of system contact shape life course trajectories and racial disparities, with a specific focus on public health histories during the early 20th century and child welfare system contact in the early 21st. Thank you so much.
Thank you. Over to me. Great. Let me just share my screen. Can we all see this on Zoom? Yes?
Yep.
Yes.
Thank you. Thank you for having me. Thank you for making this happen and allowing me to come back to Berkeley, which is a place I probably spent too many years, and very much loved it, and it sort of made me the scholar, at least, that I am today. I'm here to talk about a topic that in some ways has received a lot of attention in recent years, and that's inequality during a pandemic, and specifically racial inequalities during a pandemic. But I'm also here to talk about a pandemic that has generally been understudied, despite having sort of a couple of features that are quite puzzling and quite unique and interesting from a demographic and a sociological perspective. And in particular, I want to talk about racial disparities in flu mortality during the pandemic of 1918, which were unusually low, both for their time, which was sort of a period of extreme health inequality, and also given what we sort of generally know about the impact that public health emergencies often have on marginalized communities. We often sort of expect that they're particularly effective. And so the talk is based on a paper that we published last year. And as you can see from this list of co-authors, it was sort of really a joint effort, especially between Elizabeth Wrigley-Field and I. And so, all the labor was shared, all the credit is also shared, and the paper would look very different, I think, if those other people hadn't been on it. We are now at this tail end of one pandemic and looking back in a way through history to discuss the features of a very different pandemic. And it's, I think, tempting in that context to try to sort of understand the present by analogizing into the past and to sort of seek echoes of 1918 and perhaps the challenges we face today. Right? There's sort of, if you read the news over the past couple of years, there's sort of often 1918 emerges as one of the reference points. But if I can sort of butcher Tolstoy for a bit, every deadly pandemic is also deadly in its own way. And that's because each pandemic is caused by different viral strains. It occurs in the context of sort of different levels of medical capacity, healthcare capacity. It may elicit different policy responses, and it also occurs in some very different social environments. And so one of the questions is, how is the pandemic of 1918 unique in its own way? And I think there's sort of 3 features that make it very unique, and 2 of them are actually pretty widely known. The first one is that it was incredibly disruptive. It was called at the time the deadliest virus in history, and it caused somewhere between 50 and 100 million deaths worldwide and close to 700,000 in the United States. It was a very, very lethal pandemic, even though it was short. It only lasted about 3.5 to 4 months. The second feature that's pretty well known is that it had this very unusual age distribution of those who died. Often during pandemics, especially during influenza pandemics, we expect that the very young and the very old are particularly vulnerable, young children and older adults. And that's also the case in 1918. But in addition, we see this sort of elevated mortality roughly among those aged 20 to 40. And so we end up with this very unique, what's called a W-shaped mortality signature that makes 1918 distinct from other pandemics and also distinct from COVID-19. And so these two features, they're pretty well known.
What was it the case that the oldest ages really were, there was less mortality during the pandemic year? Is that graph indicates, or should we not take that too seriously?
I don't, compared to today,
No, it looks like during that year, maybe people stayed at home, and so there was less mortality at older ages, the very old ages, I don't know.
very old ages, the pandemic doesn't have a big impact because mortality is already so high. I'll get sort of a bit more to the age-specific data in a little bit. Right?
Martin, this is true for men.
This is true for men and women as far as I know. And so these two features, they're pretty well known. But in contrast, there's sort of a third distinct feature that has thus far received fairly little attention, because during that pandemic, the Black-white disparities in flu mortality were strikingly low compared to any other year of that period. And this is sort of widely surmised at the time. In Chicago, for example, health officials noted that the high number of deaths among white Americans was quite contrary to what would have been expected. And at least one prominent Black preacher proclaimed that God was using the pandemic to try to show the white man the folly of the empty conceit of his vaunted race superiority by dealing with them just as he dealt with the people of darker hues. And these sort of anecdotal assessments, they're also supported by life insurance data that was collected at the time and by some military statistics that the US Army collected. And so at the time, there was sort of like an awareness that something very, very unusual was going on. And unusual it was indeed, because if we look at that period, it is really a period of extreme public health inequalities, extreme mortality inequalities. Crosby talks about Black Americans being locked in a caste of poverty that made them much more vulnerable to infectious diseases. In our data, we also find that Black mortality was about twice as high as white mortality for flu deaths during that period, except in 1918. And we also know that this is sort of a period where those inequalities are sadly expected, given the very unequal living conditions faced by Black Americans, and also the fact that the healthcare system during the pandemic was rife with racism. Cities opened white-only clinics and often also triaged Black patients into very substandard systems of care. And so in many, as in many other areas of life, right, like, during that time, and especially during the pandemic, the odds were still stacked against the community in the domain of public health. And so it's sort of a surprising fact that these disparities shrink. And we wanted to understand why this happens, and perhaps more importantly, to also understand why it happened. Because it goes against these sort of like historical expectations, and it also goes against the sort of like general expectations we might have for how minority communities are impacted during public health emergencies. Right? If we look, for example, at the HIV/AIDS epidemic, if we look at some other epidemics, it's usually the case that minority communities are particularly impacted and suffer sort of higher excess mortality than other communities, white communities. And so one of the primary reasons why we know so little about this is that the data that's actually required to investigate some of these questions is pretty sparse. And so the initial challenge we faced when we tried to put this paper together was to try to understand what kinds of data we could even obtain to answer in creative ways the kinds of questions that we were interested in answering. And in the end, we compiled and used 11 different data sets. Most importantly, we relied on digitized death statistics from the Department of Commerce. And in general, these are available for larger cities, right? And so I think the smallest city for which we have monthly and age-specific data is national. And so these findings may not be generalizable to small American cities or to rural America. Right? This is sort of really a story of mortality patterns in larger cities. And we combine these data with historical census microdata to get some population counts, and also with various city-specific variables. For example, measures of segregation, measures of air pollution, measures of illiteracy, residential density, sort of other things that are potentially linked to infectious disease patterns and deaths. And finally, we construct a data set from historical newspaper records on what's called non-pharmaceutical interventions. Today, we'd probably call this social distancing measures, right? And so it's anything from the closures of schools and theaters and churches, bans on festivals and sporting events. In some cities, there's mask mandates, there's forced quarantine. And so we had a team of, I think, 6 research assistants, and we spent a couple of months going through historical newspaper data and trying to find as much information as we can. And ultimately, I think we have comprehensive NPI data for 52 of the 70 cities for which we also have race-specific death counts. Now, this is a study of mortality patterns, and so the analysis sort of syncs and flows with our ability to get the denominators and numerators right. And there's a couple of things we try to do to make sure that we are indeed getting those right. For the numerator, the number of deaths, we use city, cause, and race-specific death counts. And in our digitized data, race was originally coded as white or colored. We refer to it as white and non-white. And it basically means that outside of a small number of cities in the American West or Southwest, non-white really means black, like African American black. And in line with common practice, we estimate the number of flu deaths by combining influenza and pneumonia. And we also run several sensitivity checks where we, for example, include some bronchitis deaths. We consider all infectious disease deaths. And we also run one analysis where we combine 1918 and 1919 just to account for the fact that there's a potential spillover of the pandemic from the fall of 1918 when it sort of really happens into the spring of 1919. And so, spoiler alert, none of these have any impact on our top line findings.
So are you basically looking at all-cause mortality, or basically at this narrow
influenza and pneumonia, right? The things that are directly attributable to that pandemic. And so I should clarify this. When I say mortality, right, I mean flu mortality, right? Influenza and pneumonia mortality. Things that are caused directly by that pandemic. If we look at all causes of death, or all infectious disease causes of death, we see similar effects, but just reduced in magnitude, right? Because there's obviously sort of heart disease, cancer, right? There's sort of other reasons people pass away, old age, and they're not impacted by the pandemic. And so the magnitude of the effects is muted, but the effects are still measurable. Yeah.
Student question regarding classification, does white include like discriminated European immigrants such as Italian immigrants, Jewish immigrants?
It's a fairly
question. Just repeat the question.
Oh, sorry. The question was whether the category white includes European immigrants like Italians, and the answer is yes. It's a fairly crude scheme, right, to which we have access in the Department of Commerce data, right? And so white is basically, sort of native-born white Americans and all, if not most, European immigrants, and then non-white or colored would be African Americans. It also includes Hispanic, Latino, right? It also includes Chinese immigrants, for example, right? But in most American cities, non-white means black, African American. Any other questions on this? Yeah.
This is like where people died. They died in the city. That's not where they born.
Yeah, this is where they died.
Yep.
Yeah. These records are collected from local archives, basically by the Department of Commerce, right? This is a period of time when the death registration area sort of really expands, which is sort of includes every state where at least 90% of deaths are accurately reported according to federal guidelines. And so this is sort of really the first time in American history where we have accurate death records that are standardized, right? That include causes of death. And so for a small number of cities, the Department of Commerce basically sort of pulls together these reports that do not just include cause of death, but also race, which is sort of fairly unusual, right? Yeah.
And was there any political incentive to have higher or lower numbers of flu deaths? Did you get more funding if you had or something?
Not that I know. I'm not quite sure when these were reported to the federal government.
Yeah.
Initially, during the pandemic, early on, the government and also sort of American newspapers were pretty keen to suppress news of the spread of the severity of the pandemic, but that shifted fairly quickly, right? And this is one of the differences to COVID, for example, is just the speed at which all of this happens, right? We have basically a 4-month period where we go through this tremendous upsurge in mortality, and then it comes down again. And basically by February 2019, we're not quite back to normal, but we're sort of close-ish, right? And so all of this happens sort of fairly rapidly. We do think about whether there's a potential for sort of different rates of misreporting or underreporting of Black and white deaths, right? Is it more likely that Black death, for example, are misclassified or just go unreported? And we run some sensitivity checks in the background to make sure that that doesn't sort of swallow up the effects that we find, and it doesn't. But I think we need something like 60% of misclassification difference to have any sort of measurable effect. Any other questions? Okay, let's talk about the denominator, which is a bit more tricky in a sense. We would usually just use census counts, but in our case, we have to work around this problem that the census count for 1920 is directly distorted by the pandemic in 1918, right? There are basically close to 700,000 people, most of which would have survived into 1920 if the pandemic hadn't happened. And so we're sort of pretty hesitant to use that number because it might sort of smooth out some of the effects we're actually trying to detect. And so for our main measure of denominators, we interpolate census counts between 1910 and 1930, because this allows us to avoid some of that proximity between the pandemic and the moment of enumeration. But unfortunately, it means that we're introducing all kinds of potential additional errors due to, for example, shifting migration patterns in the 1920s. When this is a period when the Great Migration really takes off, Black Americans move from the rural South into cities. And so there's sort of potential that we're sort of trading one source of uncertainty just for a different source of uncertainty. And so we decide to run two sensitivity checks. One is that we do use the original 1920 counts just to see whether those sort of sources for uncertainty lead to a bias into a different direction. And we also derive an alternative denominator that avoids drawing on those census population counts from that period altogether. Instead, what we do is that we look at non-infectious deaths. And we sort of assume that over short periods of time, the percentage of people that die from non-infectious causes, right, cancer, heart disease, age, is relatively stable, right? And so we can get non-infectious death counts for 1910, or rather from 1906 to 1910. We can link that to 1910 census data. And so we get an estimate of the proportion of people that die from non-infectious causes. And we extrapolate that to 1918, where we have non-infectious death counts, right? We sort of make sure that those death counts aren't artificially suppressed by the fact that people also are more likely to die from the flu, right? And we sort of get an alternative estimate of population from sort of that process, right? And so we don't have to draw on any post-pandemic census counts at all. We use that as a sort of sensitivity check, right? All the results you'll see today are based on that denominator that interpolates census counts between 1910 and 1930. But again, sort of, another spoiler alert, the results are robust to all these different denominator specifications. I can pull up the exact numbers and difference if people are later interested, but it's really marginal. And this is sort of true in general for these models, right? The main issue we run into is, in some cases, statistical power. And sometimes we have to use sort of weird proxy measures. But for measures where we have sort of large numbers of observations and good data, the model specification basically doesn't matter, right? The findings are super robust to the denominator definition, to the numerator, to different sort of model, different covariates we throw into our models, and so on and so forth. We also, for some of our measures, we decompose recorded deaths into baseline and excess, right? Baseline is basically what we would expect in a given city if the pandemic hadn't happened. And excess is then the difference between that baseline and the actual reported number of deaths. We get that by extrapolating sort of pre-pandemic trend lines into 1918. With that said, let's look at some data. And first, I want to show you data on the scale of those mortality disparities relative to the pre-pandemic period. And so what you see here are the annual non-white to white flu mortality ratios, in this case for 70 American cities. And you can sort of visually see that the ratio in 1918 was much lower, right? In the pre-pandemic period, the median mortality ratio was 2.33. During the pandemic, it shrunk to 1.35, which is a reduction by 74%, right? And remember, we're talking about ratios here, and so ratio of 1 equals sort of parity, right? Equal number of, or equal level of Black mortality and white mortality. And in some cities, we can see that there is sort of actually mortality parity, which would have been very, very unusual during that period. And importantly, that reduction is also remarkably uniform across American cities. The standard deviation of those mortality ratios in 1918 was much smaller than during the pre-pandemic years. If we break that down by age, we get this picture. What you see here are 10-year age buckets. This is based on a smaller number of cities because we only have age-specific data for 20 cities rather than 70 cities, and these tend to be the largest American cities. And so what you see in each of these age buckets or panels is on the left, you see non-white and white mortality during pre-pandemic years, and then on the right, you see white and non-white mortality during the pandemic.
Could you just use the mouse to walk us through maybe the 20 to 29?
Yes.
On your computer?
Yeah. And so here you have these two are for the pre-pandemic period.
I don't see your mouse.
You don't see my mouse. Can I just, I can point it. It's fine.
Yeah, that'd be great.
So what you see here, these are non-white and white mortality for the pre-pandemic period for the age group 20 to 29, right? And here on the right side of that panel, you see non-white and white mortality for the pandemic year, right? And this is sort of replicated for all of the different age buckets.
Sorry, is this all respiratory infections or is this just flu?
This is just flu and pneumonia. Whenever I talk about mortality, right, assume that I'm talking about flu and pneumonia combined. And I want to draw your attention to two features of this graphic. One is that we observe the highest total mortality during the pandemic, once again, among the very young and the very old, which is what we've earlier seen in that W-shaped graph, right? It is also what we sort of would expect in a lot of public health emergencies, right? Especially when it comes to sort of respiratory infectious diseases. But we also see that the largest reduction in disparities and the largest excess mortality, i.e. the sort of difference between, if you will, the sort of two mortalities sort of shown for the pre-pandemic period on the left and the pandemic period on the right. The largest reduction in disparities and the largest excess mortality occurs in these two very distinct age groups, 20 to 29 and 30 to 39. And in those age groups, the disparities are almost non-existent or are non-existent during the pandemic, which also tracks in terms of the sort of age distribution with that sort of W shape that we've seen earlier. And so whatever is going on here, it may have to do something with those young and middle-aged adults.
And again, this is not just pregnant people, this is men and women?
Yes. Yeah, this is not subset by gender.
No, but I mean, this is not driven just by women?
No. And so if we summarize the evidence, I think we can sort of say that non-white to white mortality disparities shrank by 74%, by a pretty significant margin compared to pre-pandemic years. That this was primarily driven also by a higher excess mortality among white populations compared to the pre-pandemic period. Black, non-white mortality increases threefold, whereas white mortality increases fivefold. And again, this is the flu and pneumonia mortality, right? And if we break that down by age, we can see that the group that was hit hardest in terms of excess mortality, whites aged 20 to 29, their mortality increased by a factor of 20. And in those two age cohorts or age buckets that we've just discussed, 20 to 29 and 30 to 39, disparities decreased by 95 to 98%. And those reductions were, again, sort of remarkably uniform across American cities. And so the question is, how do we explain this fairly unusual and surprising finding? And so far there've been, or before we sort of did the study, there were two hypotheses that had been sort of floating around, although neither of them had been really systematically evaluated. Not for lack of trying, but just because the evidence that was available was very, very limited, and often actually quite anecdotal. And so the first of these hypotheses draws attention to local conditions of residential life. And so in particular, segregation may have somewhat accidentally insulated Black communities against centers of disease transmission and made it basically less likely that the virus could jump across racial lines, right? If you have some very insular communities, perhaps there's sort of less inter-community transmission of the flu. And the second explanation, arguably the most prominent explanation so far, is what's known as the partial immunity hypothesis. And it's based on an argument that Alfred Crosby proposed in 2003. The argument goes roughly like this. In the spring of 1918, there was a less deadly so-called Herald wave that hit the United States. And there's sort of ample evidence, right? Mortality is slightly elevated in the spring of 1918, but nowhere near what happens during the fall pandemic. And because Black communities were generally more exposed to infectious diseases because they lived in more crowded conditions, because they had less access to sanitation infrastructure, perhaps they were also more exposed to this Herald wave. And so when the main pandemic, the lethal pandemic, hits in the fall, it's possible that they had basically acquired some partial immunity by September, right? And so they're sort of more protected when that wave hits, because they're more protected, they're less likely to die if infected, right? And so in the aggregate, that sort of drives down mortality disparities. And so these are the two most prominent explanations that exist, although again, so neither has really been tested before. And so we wanted to look at both of these.
Yeah, there maybe I'm just focusing on one article I read once, but isn't there this connection with this Russian flu in 1890 or something? And that's why the young adults are like, oh, people are dying of, am I right in thinking that to die of the 1918 flu, it was this immune over response?
I'll get to that.
Okay.
You're already on my next slide.
Oh, I'm sorry. Okay.
I don't know where you read that, because that's sort of basically one of the hypotheses we try to develop here. And ultimately, I think that's sort of where the preponderance of the evidence also leads us.
It's the Canadian demographers, maybe the name, but yeah.
Okay. But so we sort of developed these two additional hypotheses based on recent work in historical immunology and also in historical social science. The first of these draws attention to basically the impact of municipal policy. There's several studies that have shown that the implementation of NPIs, those sort of social distancing measures of the day, affected mortality peaks and also affected total mortality. And so we reason that NPIs may have also had an effect on mortality ratios if they disproportionately benefited Black populations. And that's sort of analogous to an argument that Bernard Truscott made in 2004, where he argued that improvement in sewage infrastructure, which is sort of a race-neutral policy insofar as like anyone who lives in a neighborhood where they sort of put in new sewers benefits from those sewers. It had a disproportionate impact on the health of Black communities because they had a higher baseline risk of dying from waterborne diseases. And so we sort of reason analogously by saying there's sort of the potential that NPIs also had a disparately beneficial effect on the Black community, driving down mortality ratios. The fourth explanation is what we call the immunological imprinting hypothesis, which is sort of what you've just previewed and summarized for us. And so we derived this from recent work in historical virology that has shown that exposure to certain influenza strains during childhood can explain immune overreactions later in life and account for the particular W-shaped age distribution of deaths in 1918. And so we reason that same mechanism may also allow us to account for reduced racial disparities. And you can broadly think of these four hypotheses as being either about local conditions or as being about immunological histories, or alternatively, you can also think about them as being sort of short-term versus longer-term structural. And I'll go through these one by one, but I'll spend most of my time talking about the immunological imprinting hypothesis, because ultimately, as I sort of said, that's I think what the evidence ultimately leads us. But it's also the one that's the way hardest for us to test, right? And so I'm sort of curious how people feel about this process we try to develop to evaluate the still relatively sparse evidence that's available. We first looked at whether segregation may have protected Black communities during the pandemic. And if this is truly true, we would expect that communities or cities with higher segregation also experience lower mortality ratios. We use census microdata to compute 4 different indices of residential segregation. And actually, the reason why I initially got involved in that project is because I sort of put together this data set of 5 decades of like segregation indices for most American cities. And so it sort of seemed like an interesting data set to use to try to test whether that hypothesis holds any water. And in our models, in our regression models, we control for expected baseline mortality in each city. We control for the percentage of residents between the ages of 20 and 39, just because they're sort of so unusually affected, and also for the onset and the duration of NPIs. And we repeat those analyses with various other measures, residential density, illiteracy, air pollution, as our main independent variables, because they've been shown in sort of other contexts that they can affect infectious disease mortality, right? And so we're just sort of curious as an exploratory exercise whether there's potentially any there, right? Even if segregation doesn't matter, perhaps some of these other sort of local residential conditions have an effect. But the short story is that we find no significant effects. I've pulled out the sort of individual coefficients here for the sort of various variables that we test. And you can see that they're all far outside of the sort of range of statistical significance. And it doesn't matter exactly how we structure our model, what covariates we sort of throw in or take out. We always get null findings. And so none of these local conditions seem to predict those sort of unusually low disparities, which is sort of what we might expect given their uniformity, right? They're pretty uniformly reduced across the United States. So presumably the explanation will also be something that is somewhat uniform, or at least can be sort of expanded across most of the US, and it's not just concentrated in one particular city or another. But we also know from studies that cities that implemented these NPIs, these social distancing measures, sooner and also sustained them for longer, had lower mortality peaks, later mortality peaks, and also lower total mortality. There's one particular study from 2007, Markle et al., that has sort of done really a good job, and I think they were sort of unearthed early during COVID-19, right, and sort of marshaled as evidence for the potential utility of mask mandates, for example. And so we reason that an analogous logic of protection may also explain lower mortality ratios if these NPIs would especially beneficial to Black communities, right? And you can sort of see echoes of some of these debates, or some of this argument in the masking debates of the last couple of years, right? Where the sort of the argument for wearing masks is not just it protects you as the wearer, but it also protects vulnerable or potentially immunocompromised populations that you interact with, right? And so that's sort of predicated, right? Like some people are just more likely to benefit from that sort of race-neutral or population-neutral public health intervention. These NPIs, they could take different forms. Cities ban public gatherings, for example, sporting events and fairs. They closed schools and theaters and churches and bars, and they occasionally also instituted mandatory quarantine or mask mandates. And in our study, we focused in particular on the first two categories because they're by far the most common, and also they're the ones that were most comprehensively covered in historical newspapers, and so we can actually get good information on them. And our measures on the onset and the duration of these NPIs, they're based on, as I said, several months of data collection from historical newspapers, and ultimately we get good data for 52 of our cities. We also have the data set that Markle et al. Used in their 2007 study, and so basically any model where we use our NPI measures, we also rerun that model with their data to make sure that we're sort of not limited by sort of having missed anything that they picked up on, or vice versa, and it doesn't make a difference. In our models, we try to predict non-white and white excess mortality ratios using both the delay of NPIs, that is the number of days between the first reported infection in the city and the first day of NPIs, and also the duration, that is the total number of days that were active. And once again, we find no significant effect on mortality ratios. In some of our models, we see a significant association between NPI delay and mortality, which sort of tracks with existing studies, right? Cities that were basically quicker at implementing these NPIs saw lower total mortality, but we find again no effect on mortality ratios. But by far the most prominent explanation so far is what's called the partial immunity hypothesis. And this sort of hinges on the fact that spring and fall viral strains that hit the United States were sufficiently similar that exposure to one strain would potentially add cross protection against the sort of later slightly different strains, similar to the way in which exposure to one strain of COVID could confer sort of partial immunity or added immunity to a different strain of COVID. Let me just say, like, one of the benefits of giving this kind of talk now is that we've like lived through 3 years of applied science, and so also hopefully like some of these explanations make a lot more intuitive sense than they would have a couple of years ago, right? Just because like there, 1918 is not COVID, right? But there's sort of echoes in the nature of some of these debates and some of the things that people unearth and care about. And so for this explanation to be true, there's really 2 conditions that have to be met. First, the exposure to the spring wave has to have been higher among non-white communities. And second, that populations with greater spring wave exposure also need to experience lower mortality or lower excess mortality during the fall, especially once we control for things like NPIs. And the first of these 2 factors is race specific, right? We're looking for evidence that non-white communities were specifically hit harder by the spring pandemic. But the second is actually a sort of a race neutral and race independent association, right? Partial immunity would be conferred upon anyone, or likely be conferred upon anyone who was exposed to that virus, right? It wouldn't just be conferred upon white or non-white populations. And the biggest hurdle for this test, along with the sort of reduced sample size, is that we need to use spring mortality as a proxy for spring exposure, which is sort of quite a conceptual leap, right? They're not the same, but to our knowledge, there's just no records of spring exposure that exists. There are 6 non-random samples from American cities taken in the fall, partially by the US Army also. But to our knowledge, to my knowledge, that's basically the only historical exposure data that has survived, right? And so if we want to test this, we have to sort of treat mortality as a crude proxy. One problem with that, obviously, is that if infection fatality rates were different between non-white and white populations, it becomes suddenly a very problematic proxy. And so what we do is that we take that imperfect but sort of surviving data on exposure from the fall to get an estimate of how different infection fatality rates were during the fall, and we basically find that they're nowhere near enough to account for the observed difference in the spring, right? And so we sort of feel pretty confident that this is a very imperfect proxy, right? But it's a proxy that survives sort of 1 or 2 levels of scrutiny. But that's sort of a basic caveat, I would say, for these analyses. And as I said, if the hypothesis is true, we'd expect that higher spring exposure then results in lower fall mortality. This is the opposite of what we observe. And it doesn't matter if we use our own mortality measures or mortality measures from Crosby's study, who had sort of originally proposed this, but actually the data he sort of publishes in his appendix contradicts some of the hypotheses that he sort of develops in this one paragraph. Cities that are hit harder by the spring wave were also hit harder by the main pandemic in the fall. And you see this especially in the left panel, right? This is a sort of race-independent association between spring and fall mortality. And we can look at excess mortality, right? It doesn't make a difference. In our models, we control for NPIs, it doesn't make a difference. There's a very strong positive association. Cities, populations that are hit harder by the first wave are also hit harder by the second wave. However, we do find that the associations are different for white and non-white populations. For white populations, we observe that clear positive association I just described. But for non-white populations, the coefficient linking spring and fall is indistinguishable from 0, and also is statistically different from the white coefficient. We don't have the data to understand, to explain why that might be, but there's one possible and plausible explanation that is not based in immunology, but in group behavior. Recall that this was a time of incredibly high health inequality and also rampant racism in the healthcare system. And so historical studies have shown that Black communities responded to that partially by organizing healthcare and specifically infectious disease prevention at the local level, through churches, through community centers, right? And so it's possible that these sort of initiatives, so-called health weeks, may have increased lay knowledge prior to the pandemic of how to prevent, how to react to infectious diseases, and also led to greater vigilance during the fall pandemic, especially, I think, as I just said, or earlier said in response to one of Dennis's questions, newspapers were very hesitant to cover this initially, right? And so for the first couple of weeks, there's not a lot of knowledge of what's going on. And so perhaps if you have sort of a higher level of pre-existing lay knowledge, it leads to behavioral change, right? If you see people around you getting sick. We sort of have to punt on this. We can't really assess whether that behavioral theory explains that potential difference in coefficients between white and non-white communities, but I sort of want to flag this here as a potential avenue for future research. And I think especially for some qualitative archival research, this could be sort of a really interesting idea to test that may shed light on how sort of specific community responses mediate the impact of public health emergencies. We unfortunately we don't have the data. And so now we've sort of knocked down these 3 explanations, right? We have 1 left. Let's see how it fares. This 4th one is what I call the immunological imprinting hypothesis, and it's one that we've developed based on recent work in historical immunology. And those studies have found that exposure to viral strains that occur during childhood are different than exposures that occur later in life. They can have a lasting effect on immune system responses for basically the duration of the life course. And in particular, exposure to one group of flu viruses can lead to what's called dysregulated immune responses if people are then later in life exposed to different kinds of flu viruses. And this mechanism has recently been used to explain the unexpectedly high mortality, especially among those aged 20 to 39. That's sort of middle of the W-shaped distribution. Because this is precisely the generation that during their childhood experienced a pandemic that hit the United States between 1890 and 1892. It's called at the time the Russian flu. Right? We don't sort of really use geographic designations anymore, so I'll just refer to it as the 1890 pandemic. But it's sort of a previous pandemic, and precisely that generation, those birth cohorts would have lived through that pandemic during childhood and would have been imprinted during childhood with a sort of virus signature of that pandemic. And oh yeah, here on this graph, right, you sort of see how that plays out. You have the year on the x-axis, you have the age on the y-axis, and you see that people who were roughly between the ages of 26 and the late 30s in 1918, right, would have been in infancy or childhood between 1890 and 1892. This explanation hinges on the fact that 1918 was caused by an H1 virus, which belongs to the so-called Influenza A group 1. But the 1890 pandemic was likely caused by an H3 virus, which belongs to Influenza A group 2. And so exposure to viruses within the same group tends to offer added protection, right? But exposure, imprinting, and then subsequent exposure to viruses in different groups tends to lead to immune dysregulation and make death more likely. And what you see here is it's called a phylogenetic tree, sort of a diagram of the genetic similarity of different virus strains, basically. And so we have this age cohort that was exposed to an H3 virus during childhood, which may then have been more vulnerable to an H1 virus they encountered during early and mid-adulthood. And we extend that hypothesis to potentially account for reduced racial disparities as well. And the logic behind that argument is that the 1890 pandemic was especially prevalent in cities. But non-white populations at that time were more likely to live in rural areas before the Great Migration, and so it's plausible, at least, that white populations would have been more exposed to that earlier 1890 pandemic because of their urban residency, would have been more likely to be imprinted with the viral signature of that pandemic, and would thus have been more likely to suffer from dysregulated immune responses in 1918, right? And so that might explain why, as we've sort of discussed earlier, excess mortality increased threefold among non-white populations, but fivefold among white populations, right? Perhaps they're just sort of more vulnerable for that reason. Yeah.
What's the view on how likely it was this particular strain? I know during COVID, I read that there's some evidence, at least, that it was a coronavirus, that 1890 flu, and at least what I read seemed persuasive, but of course, what's the, how likely do you think?
I mean, I would love to give you a likelihood. I think, like, so far the preponderance of evidence, I think, still points to the H3 virus, right? It's difficult to find out, right? Because basically we need some historical lung tissue to look at this. and there's very, very few surviving samples. And so I don't know if that debate will sort of ever be settled. There are some studies that sort of trace subsequent immunological sort of histories of populations that were exposed to 1890 and then 1918, and sort of find some evidence that this is probably an accumulation of like H1, H3 exposure rather than coronavirus. But if we're not sort of discounting that, right? If it was a coronavirus, then basically this explanation is void. We don't know, right? And I don't think it'd be fair to say that historical virologists really know, right? I think it is sort of interesting that the coronavirus hypothesis did not come up until the coronavirus hit in 2019, right? And so there's also probably just like a lot more attention paid to like different groups of viruses that are potentially very deadly. Historically, we've sort of always thought of this as an influenza virus. One of the, I think, sort of uniquely attractive features of this explanation is that it potentially explains two of those three unusual features of the 1918 pandemic, right? Both the W-shaped mortality signature and, if we're right, also the unusually low racial disparities. And I'll try to wrap up in the next 10 minutes or so. To test this explanation, we conduct a series of empirical tests and simulations. The simulations are necessary, unfortunately necessary, because basically no data exists on historical imprinting rates. Again, you sort of need lung tissue samples to get at some of that, and they just were never collected or didn't survive. And so these simulations allow us to establish basically upper and lower bounds of imprinting that would have been required to produce the observed mortality patterns, right? And we can then compare those ranges to imprinting rates that have been empirically documented for more recent public health emergencies, epidemics and pandemics, sort of, basically sort of benchmark this is plausible enough. There are four basic conditions that have to be met in order for that hypothesis to hold water. And so let me just quickly walk through them one by one. First, was the mortality convergence actually driven by age cohorts that lived through that earlier 1890 pandemic? As we've already seen, the answer is largely yes. About 75% of the total reduction in disparities can be attributed to those two age brackets. And so we'll sort of count that as a yes, evidence in favor. Did whites have greater exposure to the 1890 pandemic? In order to answer that question, we use data from the Census Linking Project, which linked individuals across censuses. And it allows us to understand whether people who lived in cities in 1910 already lived in cities 10 years earlier. Unfortunately, we can't use any data from 1890 because, as anyone who works with historical census data knows, what happened? It all burned, right? Big fire in 1921, the census is gone. And so we sort of use 1910 as the closest approximation that we have, especially since that sort of pandemic, the 1890 pandemic, it sort of petered out roughly about around 1893, 1894. And so the 1900 census is the closest we can get. We examine all cities with linkable populations, and we find that white people were more likely to have lived in cities during their childhood, and were particularly more likely to have lived in larger cities, which is the sort of subsets of cities that we really look at in our analysis, roughly twice as likely as non-white populations. And so for the second condition, I would call that a suggestive yes. Third, that populations with greater 1890 exposure also experienced higher mortality in 1918. We're a bit limited here in the statistical power of our models, but given that caveat, we find that the percentage of city residents with an urban childhood was indeed associated with higher mortality and also with lower mortality ratios in 1918, which is what we would expect. And so, again, we have sort of a suggestive yes, although we have low statistical power for these models. I should also say that those sort of coefficients that I've highlighted here, they sort of flip in and out of statistical significance depending on how exactly we structure our model. And so we sort of less confident overall in that individual result. The fourth condition is the hardest one to evaluate because we don't have any direct data. And so instead of running any kind of regression model, we rely on some simulations that allow us to establish these upper and lower bounds. In the first stage, we conceptualize cohorts as a mixture of imprinted and non-imprinted individuals, and then basically estimate the mortality among the imprinted that would have been required to produce the observed mortality levels if we assume that non-imprinted individuals had mortality similar to adjacent regions. Right? And so this allows us to obtain basically a lower bound estimate of the proportion of individuals within each group that would have to have been imprinted. And in the second stage, we then estimate how likely that imprinting had to have been, right, to sort of produce the implied prevalence, because not everyone who sort of gets exposed to a virus also gets imprinted, right? So we sort of want to hedge our bets and sort of be true to the sort of complexity of the underlying virological science. And as you can see in this diagram, the required imprinting rates are high, generally between sort of 40 and 80 or 90%, but they're not outside of the realm of imprinting rates observed during other public health emergencies. And I should add that this sort of assumes that imprinting is the only factor that drives down mortality disparities, right? If we make room for a sort of overdetermination, right, there's multiple factors at play. Perhaps there's also a parallel behavioral pathway. Obviously, those numbers tend to come down, right? Because we essentially have to explain less of that reduction with reference to imprinting. And so for the fourth condition, we have no definitive empirical evidence, but we have sort of established a basic plausibility. And so after all this data sleuthing and after all the models, ultimately we find no evidence in favor of municipal policy, city level actions, local conditions. We find no real evidence in favor of the partial immunity hypothesis. Also, we sort of leave space for that to be reinterpreted and really resuscitated as a sort of behavioral pathway. But the one sort of potential explanation left standing, as plausible at least, is that immunological imprinting hypothesis. Let me just sort of say two more very quick things, just because we're at Berkeley and I think it's against building code to end on a positivist empirical note here. And we have to talk about some theory at least. And so let me just make two very quick theoretical claims. One is that our findings sort of lead us to conceptualize mortality patterns really as the interaction between natural history and social history, or more specifically, the evolution of different viral strains on the one hand, right, and then the concurrent histories of exposure to different viral strains of different populations on the other hand. And so a lot of work on racial disparities focuses on immediate social environments and social contexts. And we sort of argue that understanding the patterns and the drivers of inequalities in mortality may in fact require us to engage sort of more directly with these social histories and the microbial histories, and then with the structural and the institutional conditions that shape those histories of exposure over time. And when we foreground these histories of exposure as this potentially salient dimension of inequality, we can also begin, I think, to reconsider what exactly it is we measure when we measure race. Most commonly, we think of racial categories as with personal identity categories, or also as products of state classification. And we see this even in our data, right? The fact that we sort of have to crudely distinguish white and non-white populations is a fact that's imposed upon us by the public health bureaucracy of the early 20th century. It's a state effect, right? But sort of racial categories are, I think, sort of presentist in both of these senses, insofar as they preserve a record of identity and classificatory logics at the moment of enumeration.
Should probably come to an end here.
Yeah, I'll wrap up. But I think it's also sort of possible for us to think of these racial markers as what we call socially constructed proxies for group-specific histories that in turn reflect these sort of broader structures of inequality. And so when we measure race at the moment X, that variable encodes not just a particular view of racial classification at that moment, but also potentially encodes the sort of longer life course histories of differently racialized populations. And I'll leave it there.
Great. Okay, a bunch of questions on chat, but let's start with the question in the room. Did I suppress all of the questions in the room? Okay, let's start with Simia. Can you just say your question, Simia?
Yeah, I'm assuming this is gonna be a very difficult question to answer with the data, but I'm wondering about behavioral responses, because if we're looking at research from armed conflict, the natural disasters, and population health, it suggests that those who are affected by more repeated or protracted crises are sometimes more resilient compared to people affected by short-term or intense shocks. So I'm just positing if Black communities may have adopted more health protective measures, especially if they didn't anticipate any sort of support from the health system.
Yeah, thank you for that question. I mean, I think that's sort of one of the sort of group behavior pathway that we open up, and we have no way of testing that directly. I think it is, sort of, let's keep in mind, I talked a lot about a reduction in disparities, but this is still a period where in every other year, right, like Black mortality is incredibly high, and even during the pandemic, Black mortality is, slightly higher than white mortality, right? And so you would sort of expect that there's a lot of vulnerability, certainly, right? And there's also perhaps sort of accumulated knowledge of what it means to be exposed to very adverse public health conditions, but also a very discriminatory healthcare system year after year after year, right? It's telling in a way that infectious disease mortality, and this comes from a 2019 study that James Feigenbaum did with Elizabeth Wrigley-Field and Chris Muller. Black infectious disease mortality is higher than white infectious disease mortality in any other year except during the pandemic, right? And so you can sort of think about like the Black community basically living through a pandemic every single year, right? If we use mortality for the white community as our benchmark. And so you would sort of expect that that has some effect, right? Whether it is an effect at the individual level, whether it is something that is sort of sedimented into the immune system, whether it is something that manifests itself at the community level. I think we can't sort of disentangle those, but it seems to be like a sort of very plausible thing to consider.
Would group-specific behavioral responses be detectable in mortality rates for other infectious diseases?
How so, potentially?
Yeah, I mean, if it's really a behavioral effect, you should see some protection from an elevation in other things as well.
We could, yeah, that's interesting. So we could look at whether, because presumably other infectious diseases are not specifically infected by this pandemic, right? And so we would have to account for a sort of dip of, basically people that would have died from, for example, yellow fever that instead died from the flu, right? But that's an interesting idea. Can we sort of mine some of those patterns? We haven't done that, but yeah, that's very interesting.
Great, Ron, can you ask?
Yeah, can you hear me?
Yes.
Yeah. So I missed a lot because of my sound issues at this end. So this may be a silly question, but I'm wondering whether you can get single year of age mortality data, not necessarily cause specific, or even monthly or quarterly mortality data for 1918. And I think you can, because I think Doug Almond was using that kind of data in his work on the consequences in later life of the 1918 flu epidemic. And I think I remember Jim Open also using single year of death data in the brown bag he gave here for early in the century. But the idea is ignore city, ignore racial disparities, just see whether people born after the Russian flu have a real mortality discontinuity, very sudden. It should be very visible if that's going on, I would think. Yeah. Anyway, that's my suggestion.
Yeah, so I don't think those data are subset by race, right? And so we're particularly interested in racial disparities. I know there is single age data. There's also weekly mortality data, not race specific, but there is weekly mortality data for a number of American cities, and that's the data used in Markle et al. 2007 to look at the effect of MPIs. And so,
yeah, but my point is that the hypothesis is a non-starter unless it applies to the general population. If it does apply to the general population, then there's a second question of whether it can account for the convergence in mortality during the 1918 epidemic. But if it doesn't seem to hold for the general population, I don't see how looking at it the city level or the race differential level would be helpful.
There are a couple of studies that have shown that this holds for the general population, right? There's Warabe et al. 2014 and Gagnon et al. 2013 and 2015, I think. And so we don't rerun the analyses. I guess we could have done that.
Okay, no, so it's already been done. That's a perfectly good
yeah.
answer. You
Yeah,
don't need to redo it.
No, it's been shown.
Thank you.
Again, this is either Magali or Robert. I'm not sure who it is. It's Magali's account, but it's both of their names. Are Magali or Robert?
Hi, yeah, sorry, it's me. But yeah, I just dropped my question because I checked and so my question was about whether your findings are consistent with what Andrew Neumers explained about the relationship between tuberculosis and influenza during the 1918 pandemic. But I was just checking quickly, and I think the hypothesis goes the other way. It's the impact of the influenza pandemic on tuberculosis in the years after. So sorry about that.
The impact of the pandemic on post-pandemic tuberculosis deaths.
Right.
So, I mean, we didn't spend a lot of time looking at TB. I looked at a couple of numbers to basically see whether we can see a similar dip in mortality disparities in other infectious diseases, right? Because our argument, in order for our argument to hold, it really has to be a dip that's observable only in influenza-related deaths, right? And it can't carry over into other types of infectious diseases. And so I looked at tuberculosis deaths that way and basically find that they remain relatively unchanged once you sort of subtract the sort of people that would have died from tuberculosis who instead died from influenza or pneumonia. I can't tell you what the effect would be for post-pandemic years, but I can go back into the data and see if there's sort of any interesting there. And if you send me an email, I'll share that information with you.
Thanks, and thanks for the presentation. That was fascinating and very clear.
Thank you so much.
So I wanted to ask about the kind of exception proving the rule here. So here we have a disease that maybe kills you because of just some exposure to something else, not based on your own health status, not based on any treatment, not based on inequality. Is this really the only exception, or are there lots of examples of such things?
I mean, I don't know, right? But I think one of our points is that we want to push back against this, what to me seems like a fairly simplistic argument that we can sort of take lessons from one pandemic and apply them to a different pandemic, right? And especially like if we try to understand COVID in sort of through the lens of 1918 or vice versa, try to understand 1918 through the lens of COVID, we're not going to come up with the right explanation.
My push is on the racial inequality side. Are there other examples where we would expect there to be big differentials where we don't see it? It's a very unique.
I mean, I think this strikes me as historically very unique in that sense, right? I'm not aware of another epidemic that produces a comparable sort of racial signature. I think what is not unique is the fact that health histories, or what we sort of call the sort of intersection of social histories and microbial histories, can have an impact on mortality patterns during public health emergencies, right? Especially once we sort of consider how people acquire comorbidities over time. If we think about different populations being just exposed to very different diseases or being differently vulnerable to different diseases, if you sort of add that up over years, right? I think that's the part of our argument that I think we see as being transferable to actually quite a number of public health emergencies. I don't know, I can't recall any other sort of situation where we see a reduction in disparities that is as drastic and as unexpected as in this case.
I mean, the most recent thing that occurs to me is really the deaths of despair, which at least in the beginning were much stronger pattern in the white population. I think that's changing over time. Of course, a completely different story, I think, but maybe not. Okay, other questions in the room? Okay, thank you so much, Mark.
Thank you.